FTM, top surgery, is female to male. That could come in various forms. So, patients who are seeking to transition to their desired gender, oftentimes this is a double incision technique, a subcutaneous mastectomy, but there are other variations depending on patients' goals, like bat wing techniques or keyhole techniques. But this is basically chest masculinization. So, subcutaneous mastectomy or removal of the breast tissue for a more masculine or non-binary gender fluid appearance. So the age requirements for gender-affirming surgery is 19 years old. We're happy to see consultations at a younger age, 17, 18, as they approach the age of 19, where they're capable of having gender-affirming top surgery. The WPATH, or the World Professional Association for Transgendered Health, does have guidelines for hormone replacement as well as top surgery, bottom surgery. And so, if we're talking top surgery, which is what I do, things that they look for is having socially transitioned, living in as the desired gender that you want to. Typically, that would be for a year. Hormone replacement, I don't think that this is necessarily a requirement. So the seventh generation of these guidelines did have, I think, a little bit more requirements. The newer generation, the eighth, came out in September of 2022, and they don't require a lot of these. It's mostly coming down to, do you have capacity to make decision at the age appropriate limit? But I think hormones help. That said, a lot of gender fluid or non-binary patients don't necessarily want the full effects of hormones, and so I don't require them. Having your anxiety and depression well managed and having a good support system, I think, are beneficial as well. So those are typically what we look for. For a consultation, typically it lasts anywhere between like 30 to 60 minutes. Kind of discuss these background questions, whether the patient has been on hormones, when did they socially transition, any comorbidities, what effects have they seen from hormone therapy, if they have been on it, or if they're desired to go on it. We discuss pertinent background information like family history of breast cancer, if they've had any imaging or any issues on self-chest breast examinations, if they have history of binding or using trans tape, as this can change the tissue quality, how long they've been doing that or consistently been doing that, desire to have family, children, desire to breastfeed, as certainly this goes out the window with these techniques. And then really the discussion is their goals. So, their patients typically come in well versed on different techniques and what they may be a candidate for, and their overall goals, like scar pattern, whether they want nipples or no nipples. And then the examination. So assessing, volume, ptosis, candidacy for different techniques, skin quality that may impact a certain technique. And then we talk about surgery, answer any questions, certainly take photos for their chart, and then kind of wrap things up within 30, 60 minutes. After a consultation, typically we're running this through insurance. So once it takes us about 10 to 14 days to hear back regarding pre-authorization. As long as patients want to move forward with surgery, then my scheduler will open my calendar and find a date that works for them. I typically don't book out further than 5 to 6 months. We just don't do that here at Portland Plastic Surgery Group. So we'll keep a list of patients who are interested in surgery and kind of contact them, but we don't book out farther than 6 months. So typically, if I were to see a patient today for consultation, they're probably looking at having surgery in June, July. So if a patient is wanting to move forward cosmetically and without insurance, then they can see my scheduler day of and probably schedule sooner. On the day of surgery, patients come in 1 hour before the scheduled operative time. They check in, they are brought back by the nurses who get them ready for surgery, including IV access. They talk to the anesthesiologist again, as they did chat with them the night before. I come by the preoperative area about 30 minutes before surgery to do all the markings with patients and finalize the procedure. And then typically, depending on the technique, I would say the operation averages around 2.5 to 3 hours, including anesthesia time. The patient does recover with us for probably about an hour or two, and they go home the same day. So this is an outpatient procedure. So with female to male top surgery, we do prescribe narcotic medication. I prescribe a non-combination agent typically, so it allows patients to take Tylenol around the clock, later incorporate ibuprofen, and just take the narcotic for breakthrough pain. Typically, we're seeing patients only require a few days worth, some none at all, maybe just to help them fall asleep. But typically, not a lot of narcotic medication is required. We also perform regional blocks of the chest prior to surgery. So once the patient is asleep, the anesthesiologist is able to localize the nerves of the chest between the muscle layers under ultrasound guidance and perform a regional block of the chest, which makes it more comfortable for patients coming out of surgery. Recovery does depend on the technique that is used. So most commonly, we're performing double incision subcutaneous mastectomies with or without nipples. And so certainly doing nipple grafts, which are basically just skin grafts, does prolong the recovery time as those are very fragile. So starting with that, we'll say we're doing nipple grafts. The patient comes back and sees me 1 week after surgery, where we take the bolsters down over the nipple grafts. We take the drains out, and then we progress care. But typically, there's no exercise or heavy lifting for those first 3 weeks after surgery. If the patient does not undergo nipple grafts, and this is more commonly with my non-binary or gender fluid patients, the drains can come out sooner. So I typically see those patients post-op day 4 or 5 for drain removal, and they're able to get back to their activities a little bit sooner, around 2 to 3 weeks. So when we're doing subcutaneous mastectomies, we are creating a large dead space within the chest over the pec major muscle. And so we want those tissues to scar down appropriately. We don't want any fluid to build up. We're creating a raw surface area where the patient's tissues are going to be leaky. We're made up of a lot of fluid, and so that serous fluid is going to leak, and we don't want it to build up within the chest cavity. So we typically leave drains in for 4 to 5 days if no nipples are involved, or a full week if we are doing nipple grafts. And that's just not to disrupt the kind of mastectomy flap. So typically, we don't want our patients to be sedentary on the couch or just laying in bed. We do want them up and walking around. That mobilizes their blood, it opens their lungs, it gets their GI moving. And so we do want patients up and active, just no heavy lifting and nothing that's considered exercise. So nothing that gets the heart rate or blood pressure up. But certainly, it's low level activity for probably the first 2 to 3 weeks, and then easing back into normal level of activity for the next 1 to 2 weeks. So patients are typically back to their baseline activity between 4 to 6 weeks. I always cover the incisions with steri strips. Those stay on for the first 2 to 3 weeks. I have the patients in a compression garment or binder to relieve tension and pressure on the chest as well. Once I see patients at 2 to 3 weeks after surgery and we take the steri strips down, then I am okay with patients starting scar products. And so I always advise patients that silicone-based scar products are what we have the best data on in our literature as far as maturing scars. I do talk to patients, though, about, we're all predisposed to scar a certain way. And so our genetics certainly do play a big role in how we are going to scar. Typically, I am seeing younger patients who are transitioning, teenagers, 20s, 30s. And so at this age, the chest is an area of tension. And so when you're younger, these areas of tension, the body's natural response is to potentially lay down more scar tissue to widen that scar, to relieve that tension. And so I'm meticulous in placing a lot of sutures in 3 layers to relieve tension on the skin itself so that hopefully we get a nice thin scar. But I think scar products starting at 3 weeks is paramount to a good result. So if I see that they're laying down a lot of scar or having hypertrophic scarring, then we can do intralesional injections of Kenalog and 5-FU to downregulate fibroblasts from laying down a lot of collagen. And then if it continues to be a problem, then at 4 to 6 months, typically, I talk to patients about performing a scar revision, and that can be done just under local anesthesia here in the office. The trade-off is that you're trading a scar for a scar. There's always a risk that that scar could be worse than it was before. So the main 2 that I perform are variations of a double incision approach. The double incision is when patients have a lot of volume, orthosis or sag of the chest. And so we have to, in order to get a flat contour, we have to excise soft tissue. And so there's variations of that, meaning, I kind of discuss different scar patterns with patients because they have a choice. And so the most common is a more slightly curvilinear scar that follows the pec border. It, hopefully disguises that pec border or gives a more masculine appearance. Patients who are non-binary and don't want nipples may opt for more straighter scars straight across the chest. Depending on the divergence of the chest or kind of the cleavage of the chest, sometimes those incisions need to meet in the midline, as the sternum should be the most concave part of the chest. And so any redundancy there or puckering can look cosmetically inappropriate. So sometimes those incisions do need to meet. The other common technique that I do is periareolar or keyhole. And so this is an incision just on the underside of the areola. So it disguises nicely at the pigmented border of the areola. There's a lot of factors that come into play in who is a good candidate for this procedure. And the things that I look at are low volume. So typically like an A, maybe a small B cup, something less than 150 grams, because that specimen needs to come out of that incision as well. And this is a minimally invasive approach. There can't be soft tissue excess or ptosis or sag of the breast. So I'm looking for the nipple areolar complex to be above the level of the inframammary fold. As when we debulk that specimen, we're relying on the patient's elastic properties to tighten or recoil. Typically, a small nipple areolar complex, as a cis masculine areola is much smaller than a cis female areola. So something smaller and potentially even more lateralized, as the nipple areolar complex on a cis male is lateralized. And also tissue quality. So if patients have a long history of binding or using T-tape, they may have damaged their soft tissues. They may have stretched out their tissues. They may have striae or stretch marks. And so this is an indication that that tissue is unlikely going to recoil as much as I would like it to. And so if the tissue properties have been damaged, I will talk to patients about a double incision technique, because there's probably too much laxity to perform a periareolar approach. Before and after photos can be seen certainly on our website, as long as patients have given us consent to use them in that fashion. Typically, once patients follow up at their final post-op appointment where we take photos, they can check off if they're open or giving us consent to use their photos in different manners. Sometimes that can be social media, that can be the website, that can be just at consultations. And so you can see some of the before and afters on our website. But during the consultation process, there are many more photos that we have available for patients to see before and afters of what these techniques look like or what to expect through this transition. The current pricing for female to male gender affirming surgery is on our website, and there are payment plans that my team, my scheduler, can discuss with patients. To schedule a consultation with us, you can always visit our website, portlandplasticsurgerygroup.com, where you can write in and our leads will contact you. You can call us directly at our office as well to schedule a consultation, and that's 503-292-9200. Regardless, through the website or phone call, we can get you scheduled and get you in our office as soon as possible to see us.